I'm Paul Elmslie. I'm the founder and CEO of Health Set Education and the National Skin Cancer Centres. I started with my first clinic back in 1999. I was an early pioneer in the development of skin cancer practices, and over the past, well, it's a little while now, isn't it, 23 years, built, owned and operated over 40 skin cancer centres in Australia. Through, I suppose, the journey and experience of running clinics, but also, once again, general practice with some skin cancer as well as dedicated skin cancer facilities, I think what we find is that the doctors, what they really enjoy about it is that, the patients come in, they're able to conduct a visual diagnosis, make a decision around the diagnosis, whether it's through biopsy or other methods, and then be able, in many cases, to be able to treat the patient from end to end. In many cases in the past, the doctor would identify the condition, then refer that off to a specialist colleague, and really probably play no part in obviously that further management of that. So, for low-level cases, they are very easily managed at a primary care level. And with the burden of disease in Australia and many patients not getting their skin checked because they probably think that it's too difficult, you have to see a GP to get a referral to a dermatologist or the like. So one of the benefits is that the doctor's able to manage a lot more of this. The patients are very grateful because ultimately their alternative would be, once again, to wait a lot of time or a high level of inconvenience. So for a GP to be able to provide a proper head-to-toe examination with dermoscopy, be able to conduct, a punch or a shave biopsy if anything's suspicious, and then manage its management. So, if it's a small BCC on the back of a 70-year-old man, that's well within the bounds of what a GP could do. You wouldn't want to be doing anything probably facially or, cosmetically sensitive. But the fact is the vast majority of the cancers we treat are typically not necessarily on the face. So they are things that GPs can manage. But the opportunity to upskill, and like any skill you develop, you get the core knowledge and you start applying it, and you'll develop more confidence in doing this. And I think that the other thing that doctors really do enjoy is that the patient might present with something that they've identified, that it turns out is benign, but then you pick up the melanoma that they didn't even know existed. So there is probably the possibility to say that you just saved that patient's life. And I think that the doctors that we know that have been doing skin cancer work find it very, very rewarding. Skin cancer is a little bit different to, I suppose, primary care general practice in the sense that the patient turns up to get a skin check. Skin checks typically lead then to possibly to biopsies and then typically to surgical treatments. And if you look at it from a Medicare perspective, it's definitely at the upper end of what the Medicare item numbers are for a primary care practitioner to access. You can typically also charge, decent out-of-pocket fees with it because, once again, we are diagnosing and treating skin cancer. So it is something which is obviously considered important or valuable by the patient. What we also find is that skin cancer patients are recurrent patients. So, for example, if, a patient will come in for an annual skin check, if they're high risk. So rather than sort of waiting for patients to turn up when they're sick, suddenly, as you develop your skin cancer practice, you'll have these patients that will come back every 6 months or every 12 months. And like any cohort of patients, you will find the ones that have a family history or, typically develop skin cancers more commonly than others. So you end up finding this group of patients that you tend to see regularly that continue to develop, once again, things that need to be treated. And also the opportunity really is to build this into a structure or a system that the doctors find very rewarding because you know what's coming through the door, you know how to manage it, you know where your limitations lie. Whereas typically in primary care, you're not really sure what's going to walk through the door next. And now that adds to the excitement of the joy of it, but we find that doctors really do enjoy skin cancer because it's something they can become good in a sort of fairly narrow area of dermatology. Probably one piece of advice I would give to doctors if they go on a journey to develop their skin cancer skills, particularly in a primary care practice, or family practice, is to put all your skin checks in a block. So maybe it might be Tuesday mornings you're doing a skin check so that you can do skin check after skin check. You can run on time, which obviously the patients do value their time, and I think they appreciate it if a doctor could be running on time. And then allows you then to be able to do your skin checks, do biopsies whilst you're doing your skin checks. And then when you get the pathology results, you then can schedule the procedural time in your practice. So a lot of practices do have shared facilities when it comes to this. It's then being able to put time aside specifically so you can focus on doing that. And the great thing about if you created this Tuesday morning session is when people ring up and say, hey, I want to go and see, Dr. Nancy to get my skin checked, the staff know where to put them. And also if you then want to book procedures, they also know where to put them. So it doesn't happen magically on day one, but for all of the GPs that we've helped guide through this process over the years, they've found having this structured session works beautifully for them.